Michaeli. I am an REI from Mount Sinai Fertility, and I'll just quickly go to my disclosure slide. So given I'm not in person, I have no disclosures out of my main objective is for you to know me, to know that I exist. I am a relatively new staff at Mount Sinai Fertility. I started a little less than a year ago. I have particular interest in oncofertility, and I see a lot of oncology patients, both pediatric and adults. So really feel free to reach out to me at any time point and to connect. And I'm hopeful that this will be kind of a beginning of a collaboration and a fruitful working relationship. So today, my formal objectives will be to review kind of the risk of infertility in breast cancer patients and specifically focus on special considerations and maybe to address some misconceptions or myths that there are about fertility preservation and fertility treatment in patients with breast cancer or hormone-sensitive cancers, and specifically focus on a newer treatment that I'm offering and I want you to be aware of that is out there and is available to your patients, and namely talking about ovarian tissue cryopreservation. So I will start with a typical case. It's not very detailed because I wanted to keep it broad, but I'm sure that this kind of a scenario is something that you see on a daily basis almost. A young 33-year-old, a patient that has already one child and maybe started her family and desires more children, then newly diagnosed with breast cancer. Many times these people require, and you see here, I chose to be hormone positive cancer. She's generally healthy, and she's planned for neoadjuvant chemotherapy, which is the scenario in many of the young patients that you see. And we will focus on should you or how do you approach fertility consultation or address this issue in case she desires more children. So just to state the obvious, why should you be talking about it as oncologist and radiation oncologist at your first or primary or close to the beginning of diagnosis? Just because it is the absolute standard of care. I just put these snapshots from both oncology and fertility guidelines. All of them state that fertility consultation and fertility preservation are the absolute standard of care, and they should be introduced very early on in diagnosis, so there's sufficient time to conduct the procedures. And you can see here not only the international, for example, you can see the North American Fertility Society and the European Fertility Society, but also the Canadian ones. They all address fertility care or consultation as part of the initial stage of diagnosis. So now that we all agree that this is essential, I will speak a little bit to how do you identify what is the precise fertility risk? And there's no precise, but at least to categorize fertility risk future infertility risk in your newly diagnosed patients. So it's a multifactorial condition and many factors go into it. The one and primary is age. We know that the older the patient, the higher the risk of future infertility or early menopause. And this is easy, but something to keep in mind that many times, and we don't know this when we see the patient in their first consult, people vary. There is a huge variability in baseline ovarian reserve. So if you see a young patient, you might assume that her risk is not high, yet if they have a lower ovarian reserve, that invariably increases the risk for future infertility. And we can absolutely have a whole new discussion. Do people that are diagnosed with breast cancer, or even in the context of hereditary cancer syndromes like BRCA, do they or don't they have diminished ovarian reserve? And this is very controversial in the literature. So we should not assume upfront that they should have a diminished ovarian reserve, but we should keep it in mind that even a young person might have reduced ovarian reserve that puts them at higher risk of future infertility. And then, of course, a major component in the risk assessment would be what kind of regimen, what kind of chemotherapy regimen are you going to use? As you can see, I have this table here. You can see that many of the regimens that contain cyclophosphamide would be considered high risk. And you see that the same protocol can be different risk for different patient population based on their age. Last consideration would be is time. Even for patients who you do not use specifically gonadotoxic regimens, if you use and if you anticipate there will be a long delay before they can attempt conception for many considerations, either they need endocrine therapy or you would advise them to kind of you're waiting to see if they're not in relapse, then this time would inevitably again put them at higher risk for future infertility because they might age out of their normal fertility reproductive age. So this should be brought, the fertility risk assessment should be considered even in patients that you are not planning to use neoadjuvant chemotherapy. And I appreciate that kind of coming up with a fertility risk assessment is difficult. So there are multiple calculators that are available online and they can be helpful. You can always use one of these, and I'm happy to send you the presentation or to share these, or you can just scan these QR codes and you can find calculators that give you an estimation of a patient's anticipated risk based on their age, or their expected chemotherapy exposure, and many other factors. So this can be an aid so you can better estimate what would be the future infertility risk, and then you can decide together with the patient whether they should have any fertility preservation procedures or even see an endocrinologist. So just to show you, as I mentioned before, not only those who receive chemotherapy would be at higher risk of future infertility. So this is a study based from Ontario, a very interesting study that showed that breast cancer patients, even those that were not exposed to chemotherapy, still had poorer fertility outcomes. So you see that they looked at. Did you want to? Oh, maybe it was by mistake. I thought there is a question. Okay, so I was saying that people with breast cancer who did not have chemotherapy also have an increased risk of infertility, have higher prevalence of premature ovarian insufficiency and early menopause. And just so I'm sure you all wonder what's the difference between premature ovarian insufficiency and early menopause. It's just the age cutoff. Those who are diagnosed earlier than age 40 will be considered premature ovarian insufficiency, and those who are going into menopause after the age of 45, but before the age of 50 would be considered early menopause. So all of these are more prevalent in patients with breast cancer or breast cancer survivors, who even those who did not have chemotherapy. And then I think a major consideration would be you ask yourself, why send a person for fertility preservations if we think maybe it's unsafe for them to go ahead and conceive afterwards in the survivorship phase. So I think nowadays it's well established, but just to kind of reinforce this, and this is a study, a big study from the Italian group. It had they kind of collected all the meta-analyzed all the studies and looked at survivals, recurrence, and they have shown that it is safe for people who, even those who have hormone sensitive cancers, to conceive and have children after cancer diagnosis. So I think this is well established, and we can feel safe to say to patients that in your survivorship phase, if you're interested, it is an option to conceive autologous conception and to carry a pregnancy. And this brings us, after we kind of agreed on that this is possible and it is advised, what would you tell them? And clearly you don't need to do the consult, but just so you know what's out there, what can you offer your patients? So first phase is kind of to figure out, does the patient desire a future pregnancy? And I advise you never make assumptions. Even if a person already has children, some of them did not complete their ideal family size. Other situations, patients who do not have children, never assume that they want them and they would for sure pursue fertility preservation. Sometimes they're even offended if you offer them this option, or automatically refer them without kind of discussing the situation. So absolutely first ask. And then in case a person is interested, you would look at timelines and I said, okay, feel free to enter your questions and on the chat. Absolutely. So either if you have an urgent question, you can always stop me, or if you have questions, type it into the chat. Yes. So as you see, I think this algorithm is kind of easy to understand. And if we have enough time, we would absolutely oocyte freezing and embryo freezing is the absolute standard of care. This is our go-to. This is our first line. But usually does take about 2 weeks. And I'll go into more detail in a moment. But this is the first time I'll introduce that there is a more urgent strategy that we can offer patients. And we have already done this. So if we do not have 2 weeks to spare, then we can introduce ovarian tissue cryopreservation that is also considered the absolute standard of care in many, many countries. So let's talk a moment about oocytes and eggs. And again, I was kind of trying to go through quickly, so I will not say more about it because every one of these slides deserves a whole topic on its own. But even the whole concept of giving hormones to people who have a hormone-sensitive cancer, and I'm sure it is a very solid concern that both you and the patients have. And there is a lot of misconceptions about is ovarian stimulation safe in breast cancer patients. And again, a very big study from this Italian group. I'm sure you all know Lambertini, who is a breast oncologist, but he has great interest in fertility preservation. And this study, it's a fairly recent meta-analysis, 15 RCTs, and they looked at progression-free survival and recurrence rates, and they have shown that they are not different or even better in those who had fertility preservation. And I'm sure that this is biased by the fact that maybe those who were better prognosis were offered fertility preservation. So they have shown that the delay in starting chemotherapy was about 6 days on average, and it did not have a worsening, they did not have poor effects on their oncology outcomes. Another thing that always is on our minds, both us and oncologists and patients, is the time frame and the hormone exposure. So we know that when we give gonadotropins that stimulate the ovary, there is production of estrogen. So supraphysiologic levels of estrogen can actually be mitigated. We have this newer practice of giving letrozole to patients who undergo fertility preservation with stimulation, and we are really able to keep their estrogen levels within almost the normal range, really kept at bay, much lower than we expect to see in ovarian stimulation. And it was fairly clearly, and we have a lot of experience with this, we see that it does not affect their outcomes. They would still have good oocyte yield, they would still have good fertility outcomes out of these cycles, and this is why we give it to all hormone sensitive breast cancer patients, but also kind of in many other cases, even in those that have brain tumors, even in patients who we are concerned about hypercoagulability, patients who are at high risk to have clots, we give it to them and we have very good outcomes. So letrozole is absolutely an option and we give it all the time. And regarding the timelines, I'm sure you all think we remember that we were told that fertility preservation cycle or egg freezing cycle can only start with a person's period. So many times in the past, people would wait a whole month to get their period until they could start ovarian stimulation. It is no longer the case. We, for a long time now, have employed a strategy that is called random start, which means we can start stimulation at any time of the month and we would still have very good fertility outcomes. It does sometimes have an effect on the length of stimulation, but it definitely shortens the time to complete treatment. And again, it is very kind of robust and evidence-based practice. So if you had this previous concern, I think that nowadays we can safely say that ovarian stimulation can be accomplished fairly quickly. And just so you have an idea, when you are sending a patient to freeze their eggs, what are you expecting to see? What are these patients expecting to get? So these are numbers from multiple, not only oncology patients, but also elective egg freezers, but just so you have a number to tell them what would be a good outcome. And of course, it depends on the patient's age. So the younger the patients, you would require less eggs in order to facilitate a future pregnancy, and the older the patients, they would require more eggs. And we usually like to say that we are aiming at about 15 to 20 eggs as our go-to. And again, younger patients might be okay with lower number, and older patients might require higher number of eggs. And you see, unfortunately, the older patients are the one that cannot achieve this number of eggs in one stimulation. So sometimes patients would require more than one cycle. And then we always have this discussion with the oncologist, do we have enough time? And like, just so you have in the back of your mind that not always a single stimulation cycle will be enough to reach the target goal. And it's a compromise. Of course, we favor oncology treatment over accumulating oocytes, but just so you know that we usually aim at a little over 15. And to give you some practical tools. So let's say you have a patient that you identified, the patient expressed interest in fertility preservation, and you now need to arrange that for them. So where do you go? So Mount Sinai Fertility, the center I work with, we have a dedicated program for oncology patients, which means on our regular referral that you can find online, and I'm happy to send you over so you have it for your records, but on our website, this is our referral form. And then whenever you want to refer a patient for an urgent consultation, just make sure that it's very clear on the form that this is a new diagnosis. And these cases, when we receive a referral that was labeled as urgent, then we would get back to them within 24 to 48 hours. I'm sorry, there's a typo. So very quickly, they will be booked for a consultation. A consultation takes place either with our specifically dedicated nurse practitioner who sees all our oncology patients. And if she's unavailable, if it's a weekend or if it's a holiday, it's like rain or shine, these patients will be seen either by her or by a physician. We have a big team of fellows, and all our physicians see oncology patients on urgent basis. So we really see them for consultation very, very quickly. And I'll walk you through what happens to them after they see us for consultation, but just a moment about funding, because I know it's a major concern for patients and for physicians. So under the Ontario Fertility Program, urgent fertility preservation with egg freezing is covered. It only covers the actual egg freezing cycle, which means if a patient has a partner and they wish to freeze embryos, this will be for an additional fee. And the medications, the gonadotropins that we administer to stimulate the patients, are not covered. And it can be a substantial cost, but we do have an arrangement with pharma companies, and we can get them compassionate medications if they do not have private insurances. And we are very successful with this. So all in all, it will mean that these patients can freeze their eggs for free. And sometimes patients would opt out of consultations because they have a financial concern. So you can let them know that we take care of this financial piece, and we do everything we can to make it completely cost-free for them. There might be like small charges for some tests, but other than that, storage does cost, and we have a reduced cost for patients who freeze them for a prolonged period of time, like oncology patients. So just to go back to what happens after a patient comes to see us. So once we see them for consultations, we explain options, and if they decided they want to go ahead, we will touch base with the oncologist, make sure we have enough time. Timelines is always a major component of our planning, enough even the decision if we go ahead. And then if we have a green light, we can start stimulation on the same day. Like if it happens in the morning, they can come into the clinic, have their initial assessment, and they can receive the medication and start the injections on the same day. Or of course, it can happen the next day or within the next few days, but it goes very quickly. Usually stimulation takes about 10 to 14 days. In that time period, patients need to come in for blood work and ultrasound to monitor their response to the medications. It's usually about 3 to 4 visits a cycle. And then they're having an egg retrieval procedure, which is an outpatient procedure. We have it done in our clinic, which is offsite. It's not in the main hospital. It's done under conscious sedation, and that would be the end of the cycle. And then they go back to you, and patients can start patients can start chemotherapy as soon as, I don't know, the next day, on the next few days. It's not like they need a recovery period, like physically and mentally they might, but they can start very quickly after they're done their egg freezing cycle. Okay, maybe a short, brief pause if you have any questions about the process of sending patients for egg freezing or embryo freezing and the process.
Jenny, I have a question about the Gen RH Ignis in terms of like timing of administration, because I know ideally we want to administer that like 1 to 2 weeks before they start chemotherapy. But I know between like egg freezing and starting chemo, like that time frame could be really short, and they can't start. I guess they don't start the GnRH like Lupron, for example, or Zoladex before like during the egg freezing cycle. So I don't know what your thoughts are in terms
Okay,
of like.
absolutely. So I can address that. So you know what? I have a single slide because I was
Oh,
sure you
okay, great.
asked about GnRH agonist, because again, it deserves a separate. I have a slide, and then I'll answer this question when we
Yes.
talk about GnRH
Okay.
agonist on it. Or I'm happy to.
Sounds good.
Perfect. So if no other questions, I'm happy to go to our next case. So my first case was kind of a standard, what you see everyday patient. And these patients, if you consider them eligible or at higher risk for infertility, send them for egg freezing, and we will gladly see them. Then this scenario, I assume, is less common, but I'm sure you still have these cases. And this is actually a true story. This is a patient we have seen, a patient very young, newly gravid, new diagnosis of breast cancer. She was very miserable. She had a huge tumor, 10 centimeters, and it had like bulky effect that caused her to have a right arm DVT, and she literally required morphine to handle the discomfort and the pain. And she, of course, was started on anticoagulation. She was in no situation, no physical or oncology state to undergo ovarian stimulation for egg freezing, for egg harvest. And of course, her oncologist advised her to start chemo ASAP as soon as possible. So this would be a situation of a patient that has clear contraindications to have ovarian stimulation, delay in treatment, exposure to, higher risk of coagulation. Clearly, egg freezing is not the answer, but we do have a strategy. So what we offered her was ovarian tissue freezing. Let's see. Okay, where's my next slide? Okay, so this brings us back to the algorithm. Who are the patients who cannot do egg freezing? These patients, the very sick ones, the big tumors, the very young that very desire fertility preservation. Like if it's someone who is 40, we know her chances are for fertility to be successful in fertility preservation are low a priori. And then the counseling part is crucial to meet expectations. But in a very young patients, I feel like it's our we must do everything to preserve their fertility because we are treating them for curative intent, and most probably she will survive cancer. So the young patients are the best candidates for this type of procedure, talking about ovarian tissue cryopreservation. So I'm sure many of you have never heard about it, but it is a very well-established practice. And what it involves actual harvesting of a single ovary. It can be part of it, but usually we harvest the single ovary for for kind of technical and ease. And this ovary is being transported to our clinic, which means it doesn't have to happen at Mount Sinai Hospital. It can absolutely happen in Sunnybrook. And then we will transport, or the family or whomever will figure out the logistics. The ovary will come to us, Mount Sinai Hospital, and our embryologist and myself, we will process this tissue. The concept behind it, the rationale is that the eggs that will survive chemotherapy and the eggs that we're really interested in are not the mature eggs, but the primordial follicles. And we know that all the primordial follicles are already there in the ovary when the patient is born. So it makes a lot of sense to preserve the ovarian cortex that contains all the primordial follicles with the future intent of using it for conception and hormone production. And this is exactly what was done in years and years now, and it was shown to be successful in restoring fertility. So once the ovary is harvested, transported, processed, separating the cortex from the medulla, we only freeze the cortex that contains all the eggs in small pieces, and I will show you pictures in a moment. I'm keeping this slide just to explain the tissue is being frozen, patient goes into therapy, recovers, comes back in the future. How do you use this tissue? We thaw it and retransplant it back into the pelvis. So the way to restore fertility would be to have an additional laparoscopy for restoration of ovarian function by reimplantation of the ovarian pieces back into the pelvis. So in a little more detail, I'm sure that as breast surgeons and you're not afraid of these pictures, but basically what you see on one side is the way the ovary is being processed when we freeze the tissue. We aspirate, and this is kind of a side story. We can actually obtain mature oocytes directly from the tissue, though it is not the main goal of the procedure outside of those that have gynecologic cancers and cannot reimplant the tissue. So we were successful in obtaining mature oocytes from the tissue itself. But the main idea is to actually preserve the tissue itself that contains all the primordial follicles that are not ready to be fertilized. And then after the patient comes back, then the other part of the screen, what you see is, I'm not sure you can see my cursor. Let me know if yes or no. But then the tissue is being like sewn back inside either the remaining ovary or here, you can see pieces being put on the broad ligament here or on the side wall, on the pelvic side wall. As long as the tube, the fallopian tube, is kept in situ, half of the pregnancies will be spontaneous because this ovary that was retransplanted will resume function, will have follicles that normally ovulate, and then spontaneous conceptions are possible. And you will ask me, okay, this sounds very futuristic, like to take a whole organ, to freeze it, to put it back, like, does it even work? So the answer is it does. So the first baby that was, even though it started to be like they started freezing tissue in the late 1990s, the first baby was born in 2004, 20 years ago. And since then, there were hundreds and hundreds cases all over the world to the extent that the experimental label was removed 5 years ago. And it is incorporated in all fertility preservation algorithms. And there are fertility programs all over the world, everywhere. So it is. And we are at the level of having a meta-analysis of all of these reports and summaries. So when you compare head to head, embryo freezing, which is the absolute standard of care and the gold standard, to egg freezing, which was until not too long ago considered experimental. The funny part is the experimental label of egg freezing was removed in 2012, which is not long before the experimental label was removed from ovarian tissue. So compared embryos to eggs to ovarian tissue, they have completely non-statistically significant differences, very good success rates in live births. So just to show you that I'm not a crazy person suggesting this very experimental treatment. I will be 100% transparent with you. Even though you will find online gazillion of these reports about babies born, and these are already old, there is no Canadian baby that was born from this strategy for the main reason that no one or very little was frozen. So no one also came back, or procedures. I'm not aware that ever anyone attempted retransplantation in Canada, and there are no reports of babies being born from this strategy in Canada. But everywhere in the world, there are babies walking around or already in university or something. So this is the situation. I'm sure you're thinking to yourself, you say, okay, you suggest taking tissue from a person with cancer, freeze it, and then put it back in the same person who is now in remission. What about risk of relapse? And this is a very solid concern. So you can see here, this is a major, on top of our concerns. How can we check the tissue doesn't have malignancy in it? So you see that they already classified the different malignancies by the risk of having ovarian metastasis. And you see that breast cancer specifically is in two risk levels, both low and moderate, and it's all based according to the stage of disease. So if the disease is very widespread and the person has known metastasis, then their risk of contamination of the ovary would be higher compared to a patient who has localized disease and you do not think they have metastases, then the risk of ovarian contamination would be lower. And of course, we send the tissue to pathology testing as well. So we are looking to see in any relevant and possible ways, is the tissue harboring malignant cells? So for example, for hematologic malignancies, we're looking for immunohistochemistry staining. And if for malignancies, they have a specific like marker that we can locate, we would look into these. The gold standard and some things that are done elsewhere in the world, they transplant the tissue into skid mice, and then they grow these mice to see if the mice develop. Usually it's done for people with leukemia. And just so we can have a number, how often does it happen? So the report is about 4% of relapse in people who had ovarian tissue retransplantation. And this is a fairly low number. Remember, these are all people who had cancer. So they already have a risk of relapse. And you know better than me what is the risk of relapse based on patients' initial diagnosis and everything. So 4% is fairly low. And you will see this is kind of the list, and you will see that there are quite a few patients with breast cancer. So you will say, okay, do breast cancer patients have higher risk? No, it's just because so many, breast cancer is one of the primary diagnoses to have this procedure done. So this is why many of the breast cancer patients are among those who came back to have their tissue retransplanted into them. Just to summarize, I know that that was a lot of information. In terms of advantages, why would you favor ovarian tissue cryopreservation? It does not delay treatment as long as we have an OR available, and it is a major challenge to book an OR in the GTA urgently. But if we have it tomorrow, we can have it done tomorrow. We don't need to wait for a specific time of the month. We can do this as soon, even if patients have started their chemotherapy treatment. So that's a very important point. This can be done soon after, not after they completed all their chemotherapy, but if they started, they needed urgent chemotherapy and they have had one cycle of chemotherapy, it's absolutely possible to freeze their tissue because there's, of course, a dose-dependent response. It's not like they deplete all of their eggs in one go. So they still have a very good ovarian reserve in the young patients, even after first initial course of treatment. So this can be done even while they're on chemotherapy. Whenever you replant the tissue, it restores not only fertility, but also hormonal function. And I understand how you sometimes want to avoid that in some of your patients, but normally in the general oncology population, the reversal of premature insufficiency and the hormone effects is very desirable. And we know that even though that not all patients become pregnant after retransplantation, almost all of them regain hormonal function. And as I mentioned before, as opposed to the fertility treatment with egg freezing, this can also yield spontaneous pregnancies, and the percentage of spontaneous pregnancies is as high as 50% out of those who conceived, which is quite remarkable. And it, of course, can yield multiple pregnancies. So we compare that to fertility treatment. That's a huge benefit. In terms of challenges, of course, it does require specific expertise. Embryology lab, not every fertility clinic can offer this. So we have the expertise, but it's not like if you call in other fertility clinic and ask them to do this, they just cannot because they don't have the logistics or the know-how. And of course, it requires surgery or time and the obvious risks of putting someone under anesthesia. And we talked about the risk. It's a theoretical risk in terms of it's very low, but it's always on our mind. So the risk of reintroducing malignant cells is always there. Okay, let's say you have this very rare, but you have a patient that comes into a clinic, they're very sick and they still want fertility preservation and they're young and you want to facilitate that for them. What you need to do, you fill out the referral that you just saw, but just specifically state that this patient needs ovarian tissue because you do not have time to freeze eggs. So if you feel like you refer these patients and you already know that you do not have the 2 weeks or 3 weeks that we need to stimulate them, please let us know upfront. And then to make it smoother, just email me because I'm the person who centralizes all of this. So if I know it will happen, just email me and tell me, Jennia, I have this patient. Can you see her ASAP? And I will. And then if the patient is interested, and then we start coordinating the OR, which is the most complex part. But I do have a good collaboration with basically all gynecologists in the city. I sent out a gazillion emails, and I was until now successful to find an urgent OR. My main target population is children because children cannot freeze their eggs for clear physiological reasons. And then it's easier because all the surgeries are done at sick kids. And then the logistics are easier than for adults. But even for adults, it is possible. As I told you, we have done 4 cases in adults, and 2 of them were breast cancer patients, and we were successful. And as I mentioned, you can start chemo as soon as the next day or a few days later. And usually you do have a certain wiggle time. So when I send out this email, I don't say I need an OR tomorrow. I'm saying I need an OR within the week. So if you can give me a week, usually I can get an OR. Wait, sorry. Okay, this is just to summarize the pros and cons, the advantages and the disadvantages of having tissue frozen versus eggs versus embryos. I feel like we already reviewed the differences and we can go back to this slide. I'll just mention about embryos. So embryos is relevant. It is considered the gold standard, even though it's very similar in terms of success rates for eggs. There is this added component, not only the financial part, but also the ownership part. We know if we are talking about very young patients, even if they are partnered, we do strongly recommend to maintain what we call reproductive freedom, reproductive autonomy, because whenever you create embryos with a person, they automatically own half of, like, they have a say what happens to these embryos. So we usually recommend young people to freeze their eggs as opposed to freezing their embryos. Okay, alternative strategies. And as I said, each one of them deserves a separate talk. I just wanted to mention that you can use GnRH agonists during chemotherapy, and my next slide is about it, and I will answer Sandy's question in a moment. You can do in vitro maturation, which is basically harvesting eggs that are not stimulated and they're not mature, and then trying to mature them in the lab. So this has been around for years and years, but it is completely experimental. It is not a first-line treatment that we offer patients. We can in vitro mature some of the eggs that we find in the tissue. This is something else that we do, but in vitro maturation is not something that you can offer patients as a standard. Of course, patients who are cancer survivors, they can freeze their eggs in the survivorship phase. And I run a survivorship clinic, which means if you have patients who did or did not had a chance to preserve their fertility before chemotherapy, we can always see them after they're done to monitor their fertility, to assist in or hasten conception, and to offer fertility preservation in the survivorship phase. So if you have these cancer survivors, so then you fill out the same referral form, but just mention that it's for me, for my survivorship clinic. I have a specific day that I dedicate to all of these patients. So this means that I see them much quicker than just a regular consult that comes in, and then I might see them like in 3 months. So if you have cancer survivors, I'm more than happy to see them for like survivorship fertility follow-up. And of course, people can use donor oocytes, and this is also a service that we provide, and I'm happy to discuss it with patients. So to say a word about GnRH agonists. So I know that many of you use GnRH agonists in patients for oncology considerations when you want to kind of keep their hormones at bay. GnRH agonists, even though it has been around the block since the 1980s, it is still considered experimental or controversial. It's not experimental in the way that we don't know what it does or that it's not safe. It is a safe treatment. It's just not as effective. So the only thing I wanted to say about GnRH agonists, you should not put it in the same row as freezing embryos, eggs, or ovarian tissue. Freezing eggs, embryos, and ovarian tissue, all of these are fertility preservation strategies that are first line. GnRH agonist is not considered a fertility preservation strategy on its own. It was shown, and again, there is a big controversy. There are studies here and there. I think the consensus is it does decrease risk of going into early menopause, but it does not really increase life birth rate and successful pregnancies. So I think we should be careful when we're counseling patients. To address Sandy's question, that's a great question. So this idea of giving GnRH agonist injection about 10 to 14 days prior to starting chemotherapy is just because physiologically, that's the time that the ovary will be suppressed. Given that we are in a time crunch, I think it does not matter when do you give it. You just know that if you gave it on the same day of chemo administration, it will be effective just from their next cycle. And this cycle, is doomed. But as I mentioned, a single chemo administration does not deplete all their ovaries. So, and we still can freeze their tissue afterwards because we believe that there is enough oocytes left in the tissue. So it is safe, even if you cannot squeeze in this injection prior to started chemotherapy, it's perfectly fine to give it at any time later regarding the timing around fertility treatment. So technically, if you give it well enough time prior to fertility treatment, we can stimulate a patient that is under the continuous suppression of GnRH agonists. But if it's given too close to the start of stimulation, it can a little offset our practice. Usually, what we practically do when we have a patient that decided that they want to take a GnRH agonist, we usually tell her to bring it to her day of egg retrieval, and we give it right after we are done with the egg retrieval. So on the day of egg retrieval, we can give them the injection, and then they're covered for the upcoming month. Did I answer your question, Sandy?
Yes, thank you so much.
Okay. Let's see, what did I have? Okay. I'm all done, and then we'll have a few minutes for questions. The take-home message is, of course, fertility preservation consultation is a must-have. Even if a patient doesn't want to go ahead, they just need to know that it's an option and that we're there to facilitate it. And we are very approachable and easy to reach out to. So if you have some weird situations, just email us. It's safe, it's feasible, and there are multiple strategies, even for those patients who you feel that are too urgent to have ovarian stimulation. It is still worthwhile touching base with us because there are newer strategies that we can offer. Okay, so that was all I had to say. I would love to hear your thoughts. Any thoughts, experiences, any situations that you've had and you wish that you could have touched base with someone? Let me know.
I again the GnRH agonist question. I guess is that something that the fertility clinic discusses with the patient as well? Like I guess I like through my time in breast medical oncology, I'm getting a sense from different physicians in terms of who should be responsible in talking to these patients about, yes, it's not first line, but it may help with the preventing early menopause. Um, but the responsibility of like who should talk to them about it and who should administer it. Um, I guess I just want to hear from your perspective. Is that something you discuss with the cancer patients and then it gets feedback to the medical oncology team? Or in your view that it should be the medical oncology team that brings it up? I've had a patient who kind of brought up to her med onc kind of halfway through her chemotherapy. It's like, oh, I just learned about this. Nobody ever talked to me about it. And I want to do it now. And then, for me, I was just like, well, will it do anything for her then? Um, so
Okay.
yeah.
Yeah, I'm happy to address. So this is a question that also was brought up with the PMH. So I work closely with the PMH team, and they have a very nice AYA team. And we had this question, and we kind of talked about it, talked it through, and came to an agreement. So remember, we see these patients in the urgent phase to facilitate urgent fertility preservation. We see them through the cycle, and then the next time I will see them would be for fertility follow-up after they're done with their chemo. So we don't see them throughout chemo. When we're talking about GnRH agonists, these injections should be administered on a monthly or a tri-monthly basis. There is one formulation, you have Zoladex, you have Lupron, and then these are given monthly, and then someone needs to physically administer the injections because they're in like these subcute, not very patient-friendly ones. So we mention it as part of our fertility consultations. We always mention that this is not a standalone strategy, but it is an option for patients. And we say that the evidence is mixed, but there's not much harm outside of the clear side effects that are sometimes very upsetting for patients. And we are happy to give the first dose while they're under our care. But I do strongly feel that the initial, like whenever you bring up, we are going to give you this and this therapy, there are these and these and these implications. And when you mention that under the fertility implications, you will have, if you want to preserve fertility, we will refer you to REI. And there is an option to have GnRH agonist injections that then you should be continuing to give it to them because we don't see these patients after they're done with their cycle. So I think it should be brought up initially with whomever their primary physician is, and then the continuous care should be with their primary oncology provider. I will mention that the Zoladex rep told me that they have a service of administering the injection that can be very helpful for these patients. So maybe it's worthwhile to touch base with them. And because I know that PMH already have this kind of collaboration with them. So if this is helpful.
Thank you. Yes, that's really helpful to kind of be clear. Like, yes, like both medonc and fertility especially will mention it, but it should like the first injection or the subsequent injections, if the patient wants to pursue that route and get the injections, that the medical oncology team should be the one kind of
Yeah.
prescribing or
Remember,
and,
not
and doing the
all
injections.
patients will come to us. Like there will be
Yeah.
patients that will only choose to do the GnRH agonist and will not come to us. So we don't want to lose them. We only
Hmm.
those that actually want to pursue
Hmm.
fertility treatment, and this is a subpopulation. like, I guess if anyone is comfortable sharing their thoughts, like how often do you refer patients? How do you feel like, is there any, I guess, communication piece that you feel that can be improved? Because I feel like speaking with the oncologist is crucial to understand their like perception and what do they think about timelines and okay, I think we're right on time. I am, of course, happy to touch base. If anyone wants to send me an email with questions afterwards, feel free. I'm happy to share my presentation, anything that you would like to hear.
Thank you.